All right. Hi, everybody. Thanks for joining the March 2023 VTC Wilderness Medicine Journal Club. This particular month session is on women's health in the austere setting. Our family medicine VTC Wilderness Medicine Fellow, Shafali, is going to be hosting this. Somewhat branched off of the fact that she gave one of the GME lectures at the WMS conference this past February. So she's going to be proctoring this discussion, mediating questions, and then she'll be giving a presentation of her own at the end. So we're going to start with Savannah is going to present an article, and then Shafali, would you mind taking over?
Yep.
Okay. Well, thanks everybody. I will watch the recording afterwards, but like I said, I've got some other stuff I got to handle. So thanks for Shafali for taking over for this one.
Absolutely.
All right. Bye, everybody.
All right, guys. So thank you so much to Savannah and Kristen for presenting today. And thank you guys, everybody, for joining. Like Justin said, I did give a presentation earlier this year about women's health. And I think it's actually a really important topic, not just for women, but for anybody that is a provider, because I think that, I've been in this this community for about almost a year now. And I think it's something that gets overlooked sometimes, but it is something that a lot of women face problems with or are barriers to their participation in wilderness medicine activities. So yeah, like Justin said, Savannah's going to give the first presentation, then Kristen. They're going to be based off of the two articles that I found. And then if there's other things that I think I might be able to cover, I can give my presentation as well. That kind of we talks mostly about like menstrual care in austere environments, specifically like long expeditions and stuff. And if we need to, I can run through that real quick, because a lot of it's going to be a repeat of things that we've probably already talked about. Okay. Thank you guys so much. And I will give it away to Savannah.
Awesome, thanks. So I will share my screen now, and I will be covering the wilderness travel in non-pregnant females. So this is a good one, I think, just because it kind of goes over a lot more concepts and it's not so much in the weeds. So the first thing and you kind of touched on it already, Shafali, that like I sort of didn't try to think about this as like as a female, but more just like as a potential provider for females. So I think that's helpful when you're going through this article, because they're talk about objective differences, but like, so what do you do with them is really kind of the important thing. So the purpose of the article was just to highlight some stuff that is unique to females. And when I use the term female, I'm referring to biologic female sex and not so much like cultural gender. So just getting that out of the way at the beginning, but kind of going through each thing and asking yourself, like, why does it matter? And what are you going to do with that information when you're both counseling women or treating women or even just evaluating women in the wilderness setting? So first, the article talks about some basic differences in anatomy and physiology. So compared to the biologic male, women have a higher fat mass, and that results from the higher ratio of estrogen circulating in the body. They also have a lower muscle mass due to the lack of anabolic hormones. And then overall decreased components of cardiovascular output. So women on average have a lower hemoglobin than men. They have a lower cardiac output. So all of these things come into play at different stages of the wilderness trip, whether it's a day hike or a longer expedition, and also kind of in what environments you're going to be treating women in. So for example, for the muscle mass, that might affect how long you might counsel women to train for a particular expedition, because women on average can't build muscle as quickly as men or as extensively as men. So that's something to kind of keep in mind when you're advising on how to like physically prepare for a trip. And then decreased components of cardiovascular output, a lower hemoglobin and just an overall lower oxygen carrying capacity is going to come more into play in higher altitude environments where oxygen is at baseline lower than at sea level. these are the sort of things to think about. Then it goes into kind of a pre-wilderness assessment. I won't talk extensively about this section because I found a lot of it was really just like what doing an HMP is. So I was just going to highlight kind of what is specific to women. As far as the age and stage of life, so evaluating, I mean, older women are participating in a lot of expeditions and travel medicine. So understanding kind of where they're at, what are they of reproductive age? Are they postmenopausal? That's going to kind of change the way you evaluate certain complaints in the wilderness. And then regarding pregnancy, right, that's one of the biggest differences for females. So whether they're currently pregnant, whether they're trying to get pregnant, or whether it's just possible for them to get pregnant, and kind of all the things that go around that, right? So birth control, are they sexually active? Are they actively trying? And so they may not know yet if they're pregnant, but it's a higher possibility than if they're not trying. And this kind of comes into play when you're looking at travel immunizations. So I don't know all of my immunizations, but like some of the travel immunizations cannot be given to a pregnant patient. So I think yellow fever is a live attenuated vaccine. So understanding that there might be some limitations in what vaccines they can get and how that might put them at greater risk on certain trips. Additionally, they kind of allude briefly to safety. So even in the regular city, women have a higher risk of experiencing domestic violence, violence from strangers. That risk stays as well in the wilderness. So just counseling and kind of getting a sense of where the woman is going, who she's with. Is this a guided tour with strangers? Is it, who is she with? And just counseling on potential dangers for that. And then lastly, and we'll kind of get into this more a little later, but the medical kit, right? So when you're preparing for a trip that has women involved, what are you going to add to your medical kit? And so that'll be things like different medications, potentially different feminine hygiene products, things like that. They go over a couple specific exposures. They talk about altitude, and I kind of don't really know why, because they sort of say like probably not much different than men. The risk of women developing acute mountain sickness is not that higher in women. Although at the same time, I was kind of trying to reconcile like, okay, they have a lower oxygen carrying capacity. So is the risk lower really? Apparently the incidence is not much different. And also the risk of HAPE is lower, but they don't really allude to why. Additionally, this kind of got me thinking, is this just the average female that they're talking about, right? I'm 6'1". My lung capacity is going to be different than even like a 5'5" male. So understanding that there's probably some variation in terms of risk with some of these conditions. But an interesting point that they did make was regarding menstruation and contraception in terms of a thrombosis risk. So particularly in altitude and kind of the activities surrounding these larger expeditions, you run into things that might change the menstrual cycle. And whether you start introducing contraception into the mix, you can actually increase their thrombosis risk, both with contraception and with the dehydration, altitude changes, and travel that would go towards a larger expedition. So just keeping that in mind in terms of counseling. They also talk about heat and cold. So as far as women not perspiring as much as men, there is some benefit to that depending on the environment you're in. So in a particularly hot environment, you're less likely to get dehydrated because women don't sweat as much. But on the flip side, you don't cool off as efficiently and you're more exposed to hyperthermia. So how do you kind of delineate when that's a problem and when it's a benefit? They don't really get into it too much more. In colder environments, the higher fat percentage seems to be beneficial to some degree, but in more extreme cold environments, the lack of muscle mass ends up being a greater disadvantage because you're just less metabolically productive in terms of making heat. And then it kind of dives into more logistic issues, and I don't want to get too specific and like spoil anybody else's presentation, but obviously one of the biggest considerations is menstruation in the wilderness. So practical considerations, just in general, understanding that travel, stress, changes in sleep, changes in time zones, things like that can all cause alterations in the menstrual cycle. And so when you're counseling or even evaluating a patient, kind of keeping that in mind that, hey, like maybe this abnormal vaginal bleeding for you is not actually that unexpected given whatever went into preparing for the trip or whatever travel went into the trip. And then also feminine hygiene products. So they talk about, kind of disposable versus the menstrual cup. And this, I found this interesting. They allude to a study kind of evaluating some of the more infectious aspects of using either of these products. So this might be important if, a woman is trying to figure out what to do for a particular length of expedition and is concerned from an infectious standpoint, say if they've never used a menstrual cup before, highlighting that there probably isn't that much greater of a risk, and if anything, maybe even less of a risk for bacterial infections compared to the standard like tampons and pads. And then regarding contraception, they just kind of discuss, when to start that if women want to just try to avoid a period altogether. Having that kind of planning in mind, so you can't just start birth control and it works immediately, right? At least not in kind of longer term situations. And so having that kind of forethought, like, okay, if you have X amount of months, do we have enough time to get you on a cycle where you're not having any periods? And then lastly, and ever so briefly, they do kind of talk about more medical issues. So in general, vaginal bleeding, right? Huge topic. And that kind of goes back to, is your person in the wild pregnant? Are they planning to become pregnant? Are they pregnant and they don't know it? So basically overall trying to decide if vaginal bleeding in the situation is emergent or not, or kind of like I alluded to earlier, is it just breakthrough bleeding as a result of all these changes that went on in anticipation of the trip? And then additionally, hygiene considerations. Overall, it's just less sanitary in the backcountry. So women are at higher risk for UTIs. Are they sexually active in the wild? That's also a consideration. And even just in, the city, women are at higher risk for UTIs if they're sexually active. The vaginitis pathologies, including like bacterial and fungal infections. This is where you kind of start to consider bigger differences in what you might include in your kit. So keeping a couple doses of fluconazole, keeping some antibiotics that are specific to things like bacterial vaginosis and things like that, in addition to whatever antibiotics you might carry for other wilderness pathologies. So I thought that was pretty insightful. I kind of wish they would have dove a little bit more into that versus like the physical exam portion of the paper. But I think overall the article does a really good job of kind of giving multiple topics to consider when evaluating and counseling female patients. So that was it.
Thank you, Savannah. And I think you did bring up a lot of good points, and the article itself did bring up some good points too. One of the reasons that I even thought that this was kind of an important topic to talk about was I was having a conversation with someone at one of the conferences, and we were talking about what people keep in their kit. And one of the providers mentioned, they were like, well, I bring Macrobid because it treats women's UTIs. And that was really a good, interesting point, because when we're thinking about kits, personally, I didn't think Macrobid was really the best medication that I would carry. Is there any other ideas of medications you could carry that would be maybe better or equally as good to treat UTIs that might have other uses as well? And anyone can answer. This doesn't have to be for Savannah.
I think typically you would carry like doxycycline for like Lyme, right? If you have like a Lyme exposure, depending on how long you're out there. I know that's certainly not my first, second, or third go-to for a UTI. So I'd have to look in my little book to see if it even applies, but
So just in general, I think Keflex would be a really good option because Keflex treats UTIs really well, but it also treats a lot of other stuff, you know, like it can treat skin things and anything that we keep in our kit, we want them to have multiple uses. Does macrobid really have any other use other than treating UTIs? Not really. So that's something that if you're gonna carry something and you know take on that weight, might as well make it useful. And I know meds don't like carry that much weight, but if you are a medical director of an expedition, like all those little things count. So might as well think about them, right? And then the other thing that I thought macrobid was kind of an interesting thing for is in the backcountry, can you really tell the difference between pyelo and a UTI? Other than like maybe fever, like cyclic fevers and stuff like that? Not really. And macrobid doesn't treat pyelo. It only treats UTIs. So if you have a larger problem, then carrying macrobid might not be very useful for you either. So I thought that was kind of interesting. And so that was actually the thing that made me start thinking about this in the first place, that like, oh, it's not just like women's health or women's care alone. It's how does that fit into the bigger picture. So like you mentioned, bringing like fluconazole for vaginitis is great. But also along those same lines, maybe bringing metronidazole for bacterial vaginosis can be just as helpful. And metronidazole also has tons of uses, right? So you can use any belly infection for metronidazole and, you know, many other things that I'd have to look up again. But that's just something that I want you guys to start thinking about, that like, you know, what are some things that we can carry that have multiple uses, including the things that we're talking about today. Does anybody have anything to add to that?
Bactrim's also another drug that can obviously treat UTIs and skin and soft tissue infections, which are something that we'd be worried about, especially if someone has like a complex laceration. And again, Bactrim's something that can cover ear infections, bronchitis, pneumonia, and also some of the GI bugs too. And I think, correct me if I'm wrong, but I think Bactrim can also be used for traveler's diarrhea, which could be good in tropical countries.
Yeah, I think so. I think you're right, but I'd have to look that up again too. Yeah, and the only downside that I see in Bactrim is just in case somebody has a sulfa allergy. But honestly, if you're like an expedition medical director, you probably know the allergy list of the people that are joining you on the expedition beforehand. And if nobody has a sulfa allergy, I feel like that would be a great choice to make sure that you bring. So yeah, that's a great antibiotic choice as well. Yeah, anything else? That's more a little bit about like the UTIs, vaginitis, and stuff like that. But there was something else that I wanted to also kind of mention real quick that from that conversation. Yeah, say that again.
I was going to ask if I could ask a question.
Yeah, absolutely.
So this is like a really silly question. So the menstrual cup, like, is that like tampons where you have to like switch it out, or is it like a reusable, like you buy one and then like you can just reuse it, like clean it and reuse it?
Absolutely. So I actually, that's my entire presentation later during this thing. So I might have you hold on to that question because I will answer that question in like more detail than you probably want. But in general, menstrual cups they're made out of silicone, they're reusable, and you do have to take it out every 12 hours. But you can wash it and then you can place it back in the vagina to continue collecting blood. And there's a little bit of a debate on how to clean it. So I'll talk more about that as well. Okay. And then the only other thing that I thought that this article kind of mentioned that Savannah didn't already mention that I thought was kind of cool was they talked about in mountaineering, they recommend that women wear or use specialized gear for easy urination, kind of in that same area of urine UTIs and stuff like that, which I just recently found out that there was even specialized gear for that. Obviously, there's the what is it called? The shiwi, I think.
Yeah, it's almost like like an as seen on TV kind of vibe. Kind of, it seems gimmicky, but it actually seems pretty practical.
Yeah, and also like it does seem practical, and like when it is so cold outside and you have a harness on and a bunch of layers on, like taking all of that off to go urinate doesn't sound really that appealing, right? So I think that's really practical, and that's something that like not for better or for worse, that like a lot of men don't even think about. And so that's kind of the point. I just want to like bring that to people's attention. And I see that someone has a question. Hold on, let me figure out how to look at it. Would you consider bringing a tube of Monistat instead of fluconazole if you could use it as ultrasound gel? That's very interesting. Does anyone else have any opinions about that? No. So I think, so we're actually doing a research project on things that you can use as ultrasound gel that are not ultrasound gel. We don't have the answer to that yet. So it would be an interesting addition to the actual research project to see if like medicated creams would be something that would be helpful. The only thing that I would say about that, sorry, what? Okay. The only thing I would say to that is that fluconazole gel might be a little bit, or sorry, Monistat gel might be heavier than fluconazole itself. So it depends on what you're trying to achieve. If you think that you're going to need it as ultrasound gel, then maybe it might be worth it. But at the end of the day, I think maybe getting something that's specific for ultrasound versus specific for like yeast infections might be okay. But I think that's a really good thought process. And that's really putting that thought of multiple uses into critical thinking. So I love that. Anything else that anyone wanted to talk about in terms of this? So this article covered a lot of stuff that I think Kristen might also kind of briefly cover, but the new thing that Kristen's article will have is stuff about pregnant women as well. So there's lots about still, but if anyone has any comments, feel free to let us know right now. Okay. Kristen, do you mind sharing, or do you have like a presentation, or do you want to just talk about it?
Yes, I was able to put together a little presentation. Let's see.
I think you should be able to share your screen. If you have problems with it, let me know.
Okay, is this coming up?
Yep, that's
Great.
perfect.
Okay, so I think the article is kind of on like pre-participation physical, kind of like, you know, like your sports physicals for like your teens, but kind of in more of a little bit more of a wilderness context. And so kind of our outline, we're going to have a little bit of some background. We're going to have why you care. We're going to do some of the OB lingo, kind of general counseling, vaccines, altitude, envenomation, DEET, infection, and kind of non-pregnancy. So for the most part, this is more of a pregnancy type of article, which is a topic I really enjoy. So why should you care about this? So physical activity is very healthy, including when you're pregnant. It decreases the risk of numerous complications. You can encounter a pregnant person with a wilderness medical problem. For example, you're just at the local park and somebody gets, you know, a tick bite, or they're in their backyard. You can have a pregnant person in the wilderness with an OB problem. So somebody's, you know, front country camping at a national park and they develop vaginal bleeding during pregnancy. Patients ask a lot, like what they can do outside and how they can do it safely. And then, you know, certain rural communities are kind of losing their OB departments. And so kind of there might be a longer kind of transport time to get to an OB unit. And so, you know, they might be going to rural ERs or kind of other, you know, EMS or other places and kind of needing that assistance without that specialized care. And sometimes people just don't know that they're pregnant. So for it's just kind of some overview terms if you're not in the OB world. So estimated due dates, that's about 40 weeks from your last menstrual period. And if your menstrual periods are exact, that's, mostly what we use. We sometimes get a first trimester ultrasound, and as long as that's consistent with your period, we'll use your period. If there's kind of enough of a dating discrepancy, then we might use the ultrasound dating. The earlier the ultrasound, the more accurate the dating is. And once we've established that dating by that earliest ultrasound, we're not going to be kind of changing it kind of in the future. So pregnancy is divided into 3 different trimesters. So your first trimester kind of goes up to about 13 weeks and 6-7 days. So that's like the 6th day of the week. And the next day after the 6th, 7th is 14 and 0. So your first trimester, morning sickness is kind of the common theme that people have. And then once they hit their second trimester, that morning sickness usually starts to go away. So it's kind of starting around the 14th week. Sorry, that there's a typo. This second trimester goes to 27 and 6/7 weeks. And this is where you're going to start to feel a little bit of the baby bump. The uterus is going to start to come out of the pelvis. And so by about 20 weeks, the uterus is at the umbilicus. So if you have somebody, you have no idea how far along pregnant they are, if you kind of feel the top of the uterus kind of at the belly button, they're kind of about halfway. Generally, people feel pretty well and pretty good during the second trimester. They have more energy, they're not so nauseous, and they don't feel, super pregnant with kind of more back pain and a more gravid uterus. Age of viability is kind of dependent on, where you might be at. There's where, so age of viability is like 23 to 24. I see now where the 27 was in that second trimester. I don't know how that got missed. All right, third trimester. So that's kind of at your 28th week, all the way up basically until baby delivers. And so that's really a period of a lot of growth for both mom and baby. And so with that comes a shift in kind of your center of gravity. And with that can have like back pain. You're going to have a little bit more, swelling in like your lower extremities or your hands. Full term is considered 37 weeks to about 41 and 6, and your post date's kind of at 42 weeks and greater. If you go into the hospital, we might put baby on the monitor and look at the strip. So that's like electronic fetal monitoring. And that kind of lets us know baby's oxygenation and overall kind of helping to assess kind of fetal well-being in the whole clinical context. All right, so, you have somebody and they don't know their due date, or they kind of just realize they might be pregnant. How far along is somebody if you don't have their dates? So you can do a fundal height. And so that's where you are kind of pressing on that pubic symphysis bone and kind of then pressing at the top of the uterus at that fundus. And so again, 20 weeks is kind of at the umbilicus. If you measure that in centimeters, that kind of approximately gives you that gestational age. So if they're measuring at 32 centimeters, they're likely about 32 weeks, give or take, 1 or 2 weeks. And so you probably have like, some rope in your backpack. You might have a gauze packet that has like the little, measuring kind of strip on it. So that would be kind of an easy way to use things you already have to kind of determine somebody's fundal height. All right, so everything we do has risk, whether you're pregnant or not. And so you can kind of think about all the different risks for all the different outdoor activities that we all love to do. And everybody has a little bit of a different threshold for what they find is an acceptable risk. And with that, different activities have different probabilities of risk. And different severities of outcomes. So you can think, just going for a walk versus going rock climbing versus, climbing a mountain. And then different people have different probabilities for risk for the same exact activity. Some of these are modifiable. So if you're going bike riding, a person that wears a helmet versus a person who doesn't wear a helmet, that's, a modifiable risk versus, some risk factors that are not modifiable. So, two people that go up to elevation, one has COPD, and that's something they can't change, and another one doesn't. Well, the person with COPD is going to have an increased risk of hypoxia or kind of other breathing difficulties at altitude. So, pregnancy, there are both kind of those modifiable and those not modifiable risks. And so that's where kind of having that individualized care, kind of talking with their obstetrician to kind of help determine what that risk level is and what type of activities that they can do to help kind of modify some of those risks. One thing in obstetrics is if it happened once, it is more likely to happen again. And I feel like that's kind of a theme for just about everything in OB. And so that's where kind of knowing somebody's history can be really important in helping to kind of help them make the best decisions if they're planning on traveling and at different gestational ages. The CDC has a cool kind of website. So the yellow book, kind of this chapter 7, has all sorts of information on kind of counseling for pregnant patients when they're traveling. So I kind of pulled off some of their contraindications to travel during pregnancy. And so like they're absolute, so like, placental abruption where the placenta is separating from the uterus, active labor, incompetent cervix or kind of like a very shortened cervix, premature labor, premature rupture of membranes, suspected ectopic, vaginal bleeding, toxemia, or like eclampsia would all be kind of some of those more serious things. With that, with the ectopic pregnancy, if somebody knows that they're pregnant, and especially if they're going to be going on, a longer trip or something, being able to get that early ultrasound to kind of confirm that the pregnancy is in the uterus and not in the fallopian tubes would be kind of a really great idea to kind of have that ectopic pregnancy kind of drop significantly down in that differential of what could be going on or, ending up with a problem in the backcountry. So speaking of medications that you can bring, so of course, any prescription medications, hemorrhoids are a little bit more common, and constipation is more common in pregnancy. So that might be something you might consider. Antiemetics, again, whether it's morning sickness, hyperemesis, gravidarum, or just because nausea and vomiting can be pretty common. Those are important things. Heartburn is extremely common in pregnancy. So antacids, Tums, your famotidine, your omeprazole, pantoprazole would all be things to kind of consider. Prenatal vitamins, again, we were talking about like vaginitis, yeast infections. Those are things that can put a person at increased risk for preterm labor, preterm deliveries. And then urinary tract infections are much more common when you're pregnant. And this is one of the only populations where we will treat a positive urine culture, even without symptoms of a urinary tract infection, because they're at increased risk of getting like pyelonephritis and again, kind of sicker from that. And then kind of compression socks or support hose for some of that lower extremity kind of swelling. So kind of already briefly mentioned vaccines. So pregnant patients are at increased risk of basically most infections. They're considered slightly more immunocompromised. And so, basically the live attenuated viruses, vaccines we tend to avoid. The yellow fever, that's kind of that really like careful, like risk benefit, like, type of conversation that you're going to be having. So that one's going to be very individualized. Your MMRV or zoster, you're not going to be giving those. But kind of most of your other vaccines are okay. Of note, flu vaccine, super important, COVID vaccine for Tdap. So kind of one of the cool things is that we actually give that kind of around 27 weeks in pregnancy to kind of help protect baby against pertussis or whooping cough. And so if they've kind of haven't declined any of their vaccines and they've gotten all their routine prenatal cares and they get a dirty wound and they're 30 weeks or 36 weeks, then you can be pretty comfortable that they probably had gotten their Tdap vaccine. You have to give it's recommended to give the Tdap vaccine during every pregnancy. So that's kind of another way if they're really not sure if they had gotten it or not, and you don't have access to their vaccination records. If they're pregnant in the last, 5-10 years, you can kind of have an idea, again, if they don't decline the vaccine, of when they might have had their last Tdap. And then the last one, typhoid and Japanese encephalitis, they just haven't been quite as well studied as these other vaccines have. Living at altitude. Basically, when you start to get above 2,400 meters or about 7,900 feet, that's when you can start to see some increases in different conditions. So one is that there's an increased risk of like a low birth weight. And so it's about a 75.9 gram decrease for every 1,000 meters. So obviously, climbing up significantly, those numbers can start to add up. But this could also be more important if you are having more of a preterm delivery. And then, there's kind of this whole list of a lot of things that we watch out for during pregnancy that also start to increase. The article didn't really go into kind of the reasons for each of them, but it seems like there's kind of quite a few. For visiting at altitude, so kind of traveling above like 48, that might be 4,800 feet, is contraindicated in like the first trimester due to the increased risk of spontaneous abortion. And then contraindications, gestational hypertension, preeclampsia, growth restriction, fetal growth restriction, anemia, and maternal smoking can also kind of increase some of your risks. For flying, generally 36 weeks is kind of when most commercial airlines are like, okay, probably should not be flying at this point in time, just because, again, your chance of going into labor is starting to increase as well. So exercise at altitude. So ACOG kind of recommends staying less than about 6,000 feet. So that's the American College of Obstetrics and Gynecology. For Canada, they say kind of in meters, 1,800 to 2,500 meters is probably okay. But you should still take the time to acclimatize, just like you would if you're not pregnant. And then activity selection, I think, is really important. So part of that goes back to kind of the risk that we talked about before and the risk level. One of the things to start to consider is, the risk of like abdominal trauma. So for example, if you're downhill skiing and all of a sudden you like fall and you hit your belly, that, could be a pretty detrimental fall and have, pretty significant consequences for either mom or for the fetus. And then if you combine that with like a prolonged extrication time, for a long time to get to the hospital, there's a lot that could kind of go on in that period of time that could be pretty serious. In climbing, they have like climbing harnesses for pregnant patients. So that's kind of cool. And so there are different like equipment that can be modified or that has been modified for pregnancy. But again, that's still kind of, that's not for every sport and not for all activities. So, all right, so kind of going on to some of our envenomations and things. So black widow spiders, there was kind of a small study that they saw 97 pregnant patients and there was no fetal deaths. So it seems like that's a pretty low risk, relatively speaking, for a pregnancy. That compared to like your venomous kind of snake bites, so that's like your copperheads, your pit vipers, where you start to get like some edema, redness, pain. But then you can also get more systemic symptoms like the hypotension, the neurologic. But the big one, at least in pregnancy, is kind of this hematologic, where you can get like this DIC type of picture, this fibrinogen degradation that can kind of lead to like a placental abruption. And so, the treatment there is antivenom and supportive care. But when they looked at 213 pregnant patients, they found about 4% of maternal death and about 20% of fetal deaths are present with these snake bites. Now, this is mainly more worldwide. There hasn't really been the same type of picture in the US, whether that's due to increased access to the antivenom or to just healthcare in general. But again, pregnant patients are traveling internationally as well, or people are working globally. So this was just coming from the Wilderness Medical Society's guidelines in terms of like when to give antivenom, depending on kind of severity of symptoms. So for malaria, their prophylaxis drug of choices, mefloquine, and then if you can't have that due to resistance, atovaquone, proguanil, or athemethir. One of the things is we tend to avoid kind of doxycycline during pregnancy. If you have Rocky Mountain spotted fever, that's really the only choice. And so you would still give it in that setting. And then primaquine is another one that we tend to avoid during pregnancy. One of the interesting things is we don't really have a whole lot of data in the first trimester for these different medications. DEET, so helping to prevent malaria, mosquito bites, your tick-borne diseases. Overall, it's recommended, it's okay to use. Especially in the second and third trimester, there's likely kind of no harm with using DEET. The article did mention it does cross the placenta a little bit. And so just kind of with that, just remembering there's these other non-chemical methods as well. So kind of appropriate clothing choices, kind of covering your skin, kind of avoiding dawn or dusk or kind of high prevalence areas that are just known, or using like netting. Traveler's diarrhea. So pregnant patients, as I mentioned, are at increased risk of getting just different viral and bacterial illnesses. One of the things to note when you're pregnant, your blood volume increases about 1.5 times, which means you need to have that much more hydration and that much more kind of water and support. In general, we avoid the fluoroquinolones, but azithromycin would be okay for this. But otherwise, generally just kind of your supportive care for your traveler's diarrhea, as long as you're able to kind of, stay hydrated, is going to be your key thing. For non-pregnancy, we kind of already mentioned iron deficiency, anemia. And so even having just iron deficiency without like a low hemoglobin can cause kind of impaired like athletic performance. So just kind of one of those things to screen for. Menses can become irregular fairly commonly, especially if you're doing prolonged activities or high intensity type of activities. So in backpackers, about 41% had less or like shorter periods and 22% had amenorrhea. So I think that's also another important thing to kind of consider is just because somebody has amenorrhea, yes, the most common thing we think about is pregnancy, but it could just be from all of the activity that they're doing. Female athlete triad, which can happen in males too. It's kind of more with menstrual irregularities, low energy, low bone mineral kind of densities. And so the low energy isn't necessarily like just an eating disorder, but even if you just aren't eating enough because you are kind of doing so much activity, can kind of fall into that category. Suppressions, we won't go too much into that because I think that's going to be up and coming. And then, your acute mountain sickness, kind of no real significant kind of differences in those. So that's kind of the things I have. What questions do people have?
I think that was really good summary of that article. Let me see if there's any other little tidbits that I had written down. Honestly, I don't think so. It was kind of interesting because I was surprised to find that DEET was okay. I kind of figured DEET would not be, and then especially when it found out that it crosses the placenta, I really thought it wouldn't be okay, but it is interesting. And DEET is one of the best things that you can do to prevent malaria. So that is good. Has anyone ever heard of, there's like a chemical embedded clothing that they actually have now. And I don't remember what the chemical is called, but it's like the newer way to prevent malaria. I would wonder if there's some interesting data on whether that would be a safer choice than DEET specifically. That was just something that I had thought about when I was reading this as well. And then the only other thing that I noticed was when they did talk about activity specific things, while there are modifications that you can make for most activities, like rock climbing, you can have that pregnancy full body harness and things like that. There is scuba diving is always contraindicated. And does anyone remember why it is contraindicated? It's because there's a risk of nitrogen air emboli crossing the placenta. So anybody that is pregnant, do not recommend scuba diving to them. Okay. Yes, permethrin is the name of it. Thank you, guys.
So I was just kind of doing a quick Google search. EPA says, based on our review of scientific studies, there's no evidence of reproductive or developmental effects to mother or child following exposure to permethrin.
Perfect. So that would be something that would be worth actually considering to recommend as well. So that's just another thought that I had. Any questions, concerns, thoughts that any of this information has brought anyone so far?
You kind of mentioned like the right, like treating asymptomatic bacteriuria in terms of like prepping, women for their trip. Do you think with what we've read, do you think it's reasonable to do like routine UAs as part of like the pre-wilderness workup and treat accordingly? I mean, obviously if it's asymptomatic, we would never know to treat. That was just a thought I had.
Kristen, do you have any thoughts on that, especially because you're doing an OB specialty?
Yeah, so we screen everybody with like a UA like in their first trimester, and again, treat if it's positive, and we will sometimes kind of, like rescreen them throughout like the second or the third trimester. Somebody's having like repetitive urinary tract infections, we do sometimes put people on just prophylaxis during the pregnancy. And so I think that's kind of, if you have somebody and they're like, yeah, I go into the backcountry and I frequently get urinary tract infections, that might be a person you consider just putting on prophylaxis to help kind of prevent that.
Another thing that I thought, and I wanted to know your guys' opinions on this, is what would you guys consider your threshold of making recommendations to pregnant women about certain activities? So like we know scuba diving is not allowed, but like how many of you guys would recommend that a woman does go rock climbing? Do you guys feel comfortable? I think that's something that's really important to think about too, that like this data or these articles will say that yes, it's allowed, but at the end of the day, these are recommendations that your patients are trusting you with, and it's based on your comfort level, right? So I thought about that a lot, and depending on their like experience level and stuff, I would consider it, but I don't know if I would necessarily recommend that pregnant women go rock climbing unless it's something that's like really important to them. Do you guys have any thoughts about what you guys would do in that situation?
I around New Year's actually kind of had sort of this, not conundrum, but we always go up to one of the mountains in Arizona and stay in a cabin. And one of my friends was maybe 32 weeks pregnant at the time. And, I was like kind of doing my research, and it's not like we weren't 14,000 feet, but it wasn't a negligible height either. Yeah. So I was kind of going over like, okay, is it okay for her to go up at all? you know, and I sort of went through my head like, all right, I think at the point where, because I was the only medical person of my friend group, I think at the point where if she decided like, hey, I want to go on a hike, like that would be where I would potentially say like you're not pregnant right now, you know, like there are some risks with where we're at and what we're doing. I think to some degree it is kind of like how you would counsel any patient on anything, and just make sure like they're aware of all the information, right? I've seen some of those pregnant women rock climbing, and I kind of had the same reaction of like, I don't know, like you can take quite a spill even in indoor climbing gyms. But I think as long as people are like at least aware of all the possibilities, they can, just like any other patient, like make their own choices.
Mhm. Yeah, and I think that's a really good story because it brings to light that, like, you know, this isn't just as like a doctor making a recommendation for a random patient. A lot of times these are people that we care about. They can be wives, friends, you know, anybody that is related to you. And so as a medical professional, they're going to turn to you, and you usually have like a little bit of personal responsibility for their safety. So thinking about it from that lens as well, like it's easy to say that some person that I don't know, I think that's a great idea for them to go rock climbing, but what's your own threshold for letting your friend go hiking or, you know, whatever, even going to altitude and things like that. So I think having these articles and having this information can be really empowering to just make these decisions. So I really like that story. Thank you for sharing.
Can I ask Kristen on like on ACOG's website? I'm just thinking like if, you know, next year when I'm an intern, if I have to like actually counsel, so like some random person has a question about this. Does ACOG have like a lot of wilderness medicine and like travel medicine for women, like recommendations on their website? Or like if I wanted guidelines for pregnant women for like travel medicine, is there like another like organization I would have to go to?
Yeah, so they do have like some with like traveling and kind of some recommendations, you know, regarding that. And then like the CDC kind of website as well was kind of another kind of really good resource for that. So just with like the yellow book.
Yeah. And I honestly, I kind of struggled to find articles for this. I don't think there's like a lot of very specific research done on these topics. So it is kind of a difficult topic to look up stuff. You can probably look up stuff individually, but resources for overarching information can be sometimes a little bit difficult. I think a lot of resources there's a lot of information about flight recommendations in pregnant women. And to be honest with you, that is like very airline dependent. But in the general concept of it is that you want pregnant women to fly in pressurized system or pressurized planes and not like little Cessnas in the middle of Alaskan wilderness or something like that going too high. So, yeah. Anybody else have anything that they want to talk about? Okay.
A couple other ones, I think the Canadian like OB-GYN Society has one on like tick bites, or at least Lyme disease. That one was pretty good. And I think they might have also had a diving one. So they have a couple as well.
Okay. That's really good to know. Okay. And I don't want to keep you guys too long. I know it's 8 o'clock, but I would, if it's okay with you guys, I would love to kind of go over my presentation real quick, because I think it has a little bit more information than in details that we might not have covered already. The presentation that I will give you guys, it's very like nonchalant. Please answer the questions and stuff like that. I just want, really the point of it is I want to get you guys to start thinking about just some of these topics. Okay. So let me share this. Okay. And okay. So, like I said, I gave a presentation earlier on specifically strategies for menstrual hygiene and care during long expeditions. And I really enjoyed this topic because it got me thinking about a lot of things that I'd never really thought about. So I want to start with a case presentation. You have a 26-year-old female that comes to you with big news. She plans on hiking the Appalachian Trail this year. She has almost everything planned out, but she has one last question for you, which I think is a very common question that a lot of women have. It's what should I do or what should I use for my periods? So the first question that I would ask, and I want to ask you guys first question that I would ask is, what is she planning on using right now? And she said that the only thing she really knows about is how to use pads and tampons. So what problems do you guys see with her plan of using just pads and tampons in her plan of hiking the Appalachian Trail?
Disposal issues.
Perfect. Yeah. So the problem with pads and tampons, especially in austere environments, there's a lot of problems, but one of the main ones is disposal. The AT is a carry out trash environment, which means that you can't just leave used pads and tampons out anywhere. They don't have a lot of trash cans or anything like that. So a lot of women are forced to put in a Ziploc bag and carry it with them for days, sometimes even weeks, until they find proper disposal methods, which can be embarrassing, but be unhygienic as well. And then the other big thing is, what do you think? How do you feel about attracting bears if you have just used pads and tampons in your bag with you? Do you have any thoughts on how you would decrease the rate of attracting bears? Well, for people that don't know, a lot of people on the AT use bear hangs for their food to make sure that they don't attract bears or bears can't access their food when they're hiking. You can either use another bear hang, which requires a lot of resources, or some women are actually forced to use pads and tampons in their bear hang, which they also keep their food in, and then hang it on trees, which I thought was really unfortunate as well, because not only then do you have to carry it, you also have to put it right next to your food, which I didn't love that idea. And if you don't think this is a good idea, what do you think is the best option for her? Does anybody have any ideas of other things she might be able to use? We talked about one of them already.
The cup.
Yeah, the menstrual cup. So let's talk about the different options that we've got. So we already kind of talked about disposable pads and tampons. These are the most common. For people that are a little bit unfamiliar with how, like, the mechanics of or the specifics of how these work, tampons are like absorbents that you insert into the vagina for 4 to 8 hours. The recommendation is 4 to 6 hours. Now, practically, I know a lot of women that keep it in for much longer than that, but the recommendation is to get rid of them every 8 hours. And if you think about it, if they're 24 hours in a day, that's 3 tampons per day. And some women will use more if they have heavy bleeding and stuff like that. So that's like 3 tampons a day for a week. And you have to carry all of those out with you on the week that you were on your period. They are relatively convenient because they're easy to find, and tampons you can use during swimming. They do have the risk of toxic shock syndrome, and they are difficult to dispose of. Pads are like panty liners that you can use for 4 to 6 hours. Similar time frame, still really convenient, but difficult to dispose, and you can't use in water. Then there's the menstrual cup. And so this is kind of a little bit more detailed than talking about the questions that we had earlier. So this is a bell-shaped medical grade silicone collecting system that you can insert into the vagina for about 8 to 12 hours. It is reusable, and they recommend washing with tap water between uses. And it is actually hypoallergenic as well. So most women can handle it with no allergic problems. So the the article that we presented earlier, I think was maybe a little bit outdated, because when I was doing research for this presentation, there were some cases of toxic shock syndrome from menstrual cups. Not very many. It's still very low, but it was something that you want to at least consider.
Was that like in comparison to pads and tampons, or was it just like in
No.
isolation?
It was in isolation. These were
Okay.
just like studies of it. So
Sure.
not enough to really have good quality research done about it, but there are cases of it. And I actually did see the article that you had referred to during your presentation that showed that in vitro studies, it does decrease the growth of toxic shock, or like the staph toxin. But since there were some cases, I figured it was at least worth mentioning that it is something that is technically possible.
Yeah.
The other thing is that when you're hiking, how do we clean our water? Do we always have clean water readily available to us? Probably not, right? So while they say that you can wash these with tap water, you still want them to be, you want it to be decontaminated water. And that could bring up other problems, like how are you going to find decontaminated water? Do you want to use some of your filtered drinking water for this? Do you want to boil the like the menstrual cups? Which, if that's the case, that's your preferred method, you have to carry enough gas to actually get boiling water so that you can boil your menstrual cup. And that's a lot of extra weight that you have to carry just to carry a menstrual cup. So that's something else that I just want to bring to people's attention, and I want people to just think about. The other thing is that you do need clean hands for safe insertion, right? And in the backcountry, there's not a lot of options for clean hands other than hand sanitizer. And hand sanitizer can be pretty rough if introduced to genital epithelium. So that's also something to consider, that if your only method of cleaning your hands is hand sanitizer, and then you're putting your hands in your vagina to insert the menstrual cup, that can be pretty harsh on the vaginal epithelium as well. I'm not saying these things to say that the menstrual cup isn't a good option, but I do want everyone to recognize that there are pros and cons to all of these different options, and then kind of make your own decisions based on the information and things that you want to consider. So if you don't want to use either of those, there are reusable and biodegradable options as well. They have the washable pads and tampons and the biodegradable pads. The washable ones are usually made out of things like bamboo, wool, cotton, or hemp. They are considered environmentally friendly. However, they can be difficult to clean because you have to use clean water. So similar problems with the menstrual cup. They can be heavy and bulky, and they move during exercise often. The other thing is that when you wash them, you have to dry them. And if you're on the move every day, especially for somebody that's like hiking the Appalachian Trail, how are you planning on drying these things? A lot of women don't find any other way other than putting it on their pack in the sun to dry it, which for some women, totally fine. But some women, it could be really embarrassing and something that they don't pick this option for that reason alone. So just kind of considering these things is really important. Biodegradable pads are considered affordable, and they are easy to decompose, and they have some antibacterial properties built into the actual material of the biodegradable pads. So that can all be really good. The downside to biodegradable pads is that the soil can retain infective agents and contaminate water sources. So this is less applicable, or there's not as much research done about like bacteria and infectious agents that are relevant to the Appalachian Trail. But there was a study that was done that HIV and hepatitis can actually retain its infectivity in soil for up to 6 months after having used biodegradable pads to like bury them in the soil. So that's kind of a big deal. Not saying that all our women have the HIV or hepatitis, but to think about other things like giardia or traveler's diarrhea, things like that. If HIV and hepatitis can be in the soil for 6 months, like we don't even know how long the other infectious agents can contaminate water sources for, you know? Any questions so far? I know I'm kind of talking a little fast, so I just wanted to pause and make sure no one has any questions. Okay. So the big thing that I wanted to talk about, those are all the non-menstrual suppression options. The big one that I wanted to introduce to you guys today is menstrual suppression. Menstrual suppression is basically any form of hormonal therapy that is used to control when a woman has their periods. So there are lots of different options, and I'm going to go through each of them in a little bit more detail. The big thing that we've already mentioned is that a lot of these they need to be started about 90 days in advance to the woman actually going on their expedition, because women can have irregular bleeding or even increased bleeding for up to 3 to 6 months after starting any of these options. So if you started the week before she goes on her expedition, she might have a really horrible time on the expedition and might have to come back just for things like menorrhagia or irregular bleeding. While I just want to make a little point about the fact that a lot of these options for menstrual suppression were originally created as contraception. While that's not the point of what I'm talking about today specifically, I do want people to think about the fact that the effectivity of contraception can be something that a woman considers when she's picking options for menstrual suppression. So if in terms of things that you're thinking about, the pills, the most common, but if she knows that she's going to have sex and she wants something that protects her from pregnancy, an IUD might be something that you want to consider because it has a higher rate of effectiveness in terms of contraception as well. So this is just a little table that shows the effectiveness of each contraception method. So the oral contraceptive pill is the one that most people think of when they think of menstrual suppression. There are two different types of pills. There's the COCs and the POPs. The COCs being the combined progesterone and estrogen pill, which you have to take daily. And then there's the progesterone only pill as well. The amenorrhea rate for women on COCs can range between 49 to 88%, and it is higher with prolonged use. So that's a pretty wide range of like amenorrheic rate. So really it's pretty unpredictable how the woman that you're counseling will react to COC specifically. The nice thing about like OCPs is that you can manipulate their periods so that you can have them every week, every 3 months, or even every year, like once every year. And that can be really helpful. The downside is that the pills have to be taken daily around the same time to be effective. And they can have breakthrough bleeding and other side effects like mood swings and contraindications, like can't be used in women that are smokers, have uncontrolled heart problems, or like history of DVTs. The progesterone only pill has a similar amenorrheic rate to COCs. They can be used in women that have some contraindications to COCs, including postpartum women and breastfeeding women. The cons to it are that they have very similar side effects, including the mood swings and breakthrough bleeding. And you also have to take it daily as well. Yeah. So other options that you can use if you don't want to use the pills, you can use the hormonal patch or the vaginal ring. So the hormonal patch is applied to the lower stomach or buttock weekly with occasional patch-free weeks, which is when you induce the periods. It has limited data about the amenorrheic rate, but the ACOG considers it a moderate amenorrheic rate, and it has better compliance due to the fact that you only have to apply it weekly. It can have skin reactions because it is, at the end of the day, like basically a sticker that you're applying directly to the skin. It does have the same hormones as OCP, so it has similar side effects, and it has a reduced efficacy in women that are greater than 90 kilograms. The vaginal ring is a small silicone ring that is, silicone and hormonal ring that's inserted in the vagina every 3 to 4 weeks. It has a pretty good amenorrheic rate of 89%. And the nice thing is that the newer rings are reusable and can last up to a year, which I think is really cool. So basically the way that works is that you put in the ring for 3 weeks and then you take it out for a week, but then you can put the same ring back in afterwards because it is reusable for the next 3 weeks. And similar to OCPs, you can manipulate how often you have periods. So you don't have to take it out every month. You can take it out every 3 months, just knowing that it's not going to last you a full year if you do that. It does have similar contraindications to OCPs. It is a little bit more difficult to insert because, well, for various reasons, but also similar to the menstrual cup, you want to make sure that your hands are clean when you do insert them. And it has higher rates of breakthrough bleeding than most menstrual suppression. The next option that I wanted to talk about is the Depo-Provera, which is an injection in the arm that you get every 3 months. It has an amenorrheic rate of 68 to 71% after 2 years of use. And it can be a convenient middle ground for people that don't want the daily OCPs or the long-term IUDs. And the nice thing is that after you give the original shot, you really only need nurses' visits afterwards, after the initial injection. The problem is that if you run at all out of the 3-month window, then you have to see a physician again. And for women that don't have consistent like care available to them, that might be difficult. And you also have to think about if someone has a long expedition, like hiking the Appalachian Trail, 3 months in, they are in the middle of their trail with no known established doctor in the area. Like, how are they going to get their repeat injection? So just kind of thinking about that is really important as well. It also does decrease bone mineral density, but this decrease in bone mineral density is actually reversible as well. So like reversible once you stop the Depo-Provera. The next one I wanted to talk about is the hormonal IUDs. These are reversible T-shaped implants that are placed in the uterus. The big downside to this one is that there's a lot of miseducation around it, and it requires an appointment for insertion alone. The nice thing about these are they last 5 to 8 years. The Mirena actually just got approved for 8 years just like recently. They have a varying amenorrheic rate based on the amount of hormones that are in them. The Mirena has the highest, being 50%, and the Skyla has only 6%. They are considered the most effective birth control, and they do not affect fertility, which is really great. They do have higher rates of breakthrough bleeding as well. And one thing that I do want to mention is that things that are not recommended for this particular instance of hoping to gain amenorrheic rates or controlling menstrual care for women is that copper IUDs and Nexplanons are not recommended due to menorrhagia and increased bleeding rates. So even though they're great for contraception, they're not good in this situation. Even though the Nexplanon has an amenorrhea rate of 22%, which I thought was kind of interesting. And then finally, the one that I feel like probably not a lot of people know about at all is the GnRH analogs, which is the Leuprolide. This is a hormonal therapy that induces hypothalamic suppression. It can be an IM or sub-Q injection that you get every 1 to 3 months for up to 6 months. And it has an insanely high amenorrheic rate of 73 to 96%. While it is highly effective and it is reversible, it is more indicated in women on chemotherapy and in women with breast cancer or endometriosis. So this isn't really a realistic choice for everyone. But if you do find a woman that has these particular situations, it might be something that you can think about. Granted, if you're on chemotherapy, like what are the chances that you're actually going out into the woods for long periods of time? Probably not high. The other thing about this option is that it is extremely expensive, and it does decrease bone mineral density that is not reversible. So they do recommend add back therapy, which helps with the decrease of bone mineral density. This is a chart that I found that it kind of just summarizes all the things that we talked about. It has the benefits, the difficulties, and the risks of all of the different options that we talked about. So if anybody wants this PowerPoint afterwards, just let me know. I thought this was like a nice little table. And then I would be remiss if I didn't talk about every option that a woman has, right? So while it's not common, sterilization is something that you should still offer to a woman, and they have a right to actually know information about it and choose it if they want to. The two main causes or types of sterilization are salpingo-oophorectomy and hysterectomies. And the benefits to some women are that it's permanent. cons for some women are also that it is permanent. So you really should talk to the woman that you're counseling and see what their like motivations are, and really be sure that this is something that that would be the best option for them. The other downsides to sterilization is that it is expensive. It has surgical risks attached to it. And afterwards, you will experience severe postmenopausal symptoms that are irreversible. So, maybe not irreversible, very difficult to treat. So just making sure a woman is really aware of all of the side effects before they actually opt out or opt for these options is kind of important. So we talked a lot about the different hygiene and disposal problems and considerations in the outdoors, but this is kind of just a little bit of an overview. Things that I might not have mentioned before is that, especially with like the hand sanitizer or like not clean hands, introducing that into the vagina, the disruption of the vaginal microbiome can lead to bacterial vaginosis and yeast infections. So just kind of being aware of that as well. Super important. And we've talked about this ad nauseum, so I'm not going to focus on this too much, but it is important. There's very little education, and a lot of wilderness medicine or wilderness areas have limited access to pads and tampons. And menstrual cycles can be debilitating for women, right? It can cause anemia, which can cause tiredness. It can, like carrying medications that treat menstrual cycles, like ibuprofen and Tylenol. It's great, but you might be using those resources to treat a menstrual cycle, rather than if someone later down the road sprains their ankle and needs some ibuprofen and Tylenol, you've probably already used up all your resources on the period cramps. So kind of just thinking about allocation of resources can be important as well. And not so much for the Appalachian Trail, but for a little bit more of like more dangerous goal-oriented expeditions, period cramps and hormonal imbalances can halt performance and sometimes can impede expedition completion, or in some cases even survival. So it is important. That's kind of just the thing that I want to have most people take away from this. And yeah, that's everything I've got. Does anybody have any questions or thoughts?
Hi, I put a question in the chat. I was just wondering, in that short amount of time that these patients might be taking the leuprolide to suppress their menstrual periods, are they going to be feeling those menopausal symptoms within that time, or does it usually take a while for that to onset?
You know, I don't know for sure because there isn't a lot of data that I looked into specifically around wilderness medicine uses for that, but that's a really good question. I would assume from the research that I did do that leuprolide was very well tolerated. So I would say that it's probably not as bad of postmenopausal symptoms as other things might be.
Interesting, thanks.
Mm-hmm. And I'm sorry, guys, I did not have access to the chat. So if you guys put anything in the chat, I did not see it. Yeah. Yeah, and I would be happy to share this with anybody that's interested in this. I will definitely. And does anybody else have any questions, concerns, or comments? No? Well, guys, I think that is it for us tonight then. I thank you guys so much for joining me. And I really enjoyed talking to you guys about this. I thought that I kind of geek out about this topic, so I'm really glad that you bared it with me for about an hour and a half. If you guys have any questions, I'll be on for like a little bit longer, but otherwise have a great night. Okay, guys?
Thank you.
Mm-hmm. Thank you, Kristen.